Hello, everyone. Welcome to this month's POCUS Spites webinar. And we'll get started now. Thank you for joining us. And my name is Daria, and I will be your webinar host today. The webinar is now beginning, so all lines have been muted. Please use the Q&A box for any questions or chat box for any comments you have throughout the webinar. Today's topic is vascular application of POCUS. Now speaker is Dr. Eugene Zeeler. Dr. Zeeler is a professor of vascular surgery at the University of Washington School of Medicine and medical director of the D.E. Strandis Junior Vascular Laboratory at the University of Washington Medical Center and Harborview Medical Center in Seattle. He received his physician degree in 1976 from the Johns Hopkins University School of Medicine. This was followed by a general surgery residency at the University of British Columbia and a vascular surgery fellowship at the University of Washington. Dr. Zeeler's research interests have focused on the clinical application of non-invasive diagnostic techniques of vascular disease. He has served on the committees and board directors for the American Registry for Diagnostic Medical Sonography and the Alliance for Physician Certification and Advancement. He also served on the Joint Review Committee on Education and Diagnostic Medical Sonography and is a past president of the Intersocietal Commission for the Accreditation of Vascular Laboratories. Dr. Zeeler is currently Vice Chair for the IntelliUS POCUS Certification Academy Council. Welcome, Dr. Zeeler. We're so excited to have you today. Thank you for taking the time to present.
Sure. Well, thank you, Daria. Nice introduction. And hello, everybody. Good morning or good evening or good afternoon or whatever time it might be. It's actually 9 o'clock in the morning here in Seattle. So I'm going to go ahead and share my screen, get started. So I'm going to talk about, I'm a vascular surgeon and I've been involved with vascular ultrasound for a long time. And so I thought I would talk about vascular applications of point of care ultrasound, since this is obviously a point of care interested audience. And, those of you that have been involved with point of care ultrasound know that the whole point of care ultrasound field has been facilitated by the availability of these new or newer, small, portable, relatively inexpensive, and relatively easy to use instruments that can be used not for a formal diagnostic study the way we do in the vascular lab or in a radiology department, but at the point of care for facilitating a diagnostic or a patient care encounter. So the goal is basically to acquire some additional information that can be used immediately to care for the patient. And of course, there are a variety of applications of point-of-care ultrasound. They are involved with virtually any medical specialty that you could think about. But if we just go down to the bottom here and look at the vascular applications, the ones I thought I would touch on today are screening for deep vein thrombosis in the lower extremities, screening for abdominal aortic aneurysms, assessing the lower extremity for arterial ischemia, vascular access, and then complications of vascular access. So those are some of the vascular applications. And most of the vascular point of care applications are either abbreviated or simplified versions of the complete diagnostic test that we do in the vascular lab if a patient's referred for a formal study. But in every case, the goal is to answer a specific usually a small question or guide a procedure. And the interpretation part of the exam is typically very clear, simple, and straightforward, that something is either present or absent, or it's normal or abnormal or something like that. It's not a question of fine points of a classification. So let's get started with the first application. This is the two-zone compression ultrasound for proximal lower extremity DVT. And when we talk about deep vein thrombosis in the lower extremity, we tend to divide it up into the proximal or above knee DVT and distal or below knee or calf DVT, with the dividing line being the popliteal vein. So if the popliteal vein is involved, it's an above knee deep vein thrombosis. And the reason that this distinction is important is that if there's a proximal or above knee DVT, the patient's at high risk for a clinically severe pulmonary embolism if they're not diagnosed and treated appropriately. For the distal or below knee or calf DVT, there's a lower risk for a clinically significant pulmonary embolism. So even though there is, those are important to know about, they're not as critical as the proximal or above knee. So this screening test is really directed towards those proximal DVTs. And so what this means is, in terms of the two zones, is that we examine two segments, the common femoral vein and the popliteal vein, for compressibility or the presence of thrombus. And this relies on B-mode imaging alone. Doppler is not required, and compressions are always performed in a transverse view. And the reason that this test works as well as it does in the outpatient ambulatory care type setting is that if a patient does have a proximal deep vein thrombosis, one of these two segments is almost always involved. So it doesn't really tell us the extent of the DVT, but it just tells us that the DVT is present, which is, of course, what we expect a good screening test to do. To do this test, we don't need a very fancy machine. Almost any good B-mode imaging system will do. It helps to have a selection of transducers, low frequency transducers for deep legs or large legs, and a higher frequency transducer for more superficially located structures. There are only two adjustments we need to worry about for the image: the B-mode gain and the B-mode depth, as shown on this particular instrument. And the gain, as many of you I'm sure know, is just the amount of signal amplification or brightness in the image. And the object of setting the gain is just to get a good range from dark to light or black to white in the image, and so it's not too bright or not too dark, so we can see the details more clearly. And the depth setting, obviously we don't have any control over the depth of where the vessels are, but the object here is to keep the vessels of interest or the points of interest as close to the top of the image as possible and in the middle of the image so that they can be seen clearly. As far as the exam itself, the exam can generally be performed with the patient lying supine and the leg externally rotated, as shown in the top image there. And that gives good access to the common femoral vein from the inguinal ligament distally. It helps to identify the common femoral vein at the inguinal ligament and then compress in segments down, and in about 4 or 5 compressions one can examine the whole common femoral vein. The popliteal vein is accessed from behind in the popliteal fossa, and I find it easiest to locate the popliteal vein right around the level of the joint line and then compress and visualize it up into the adductor canal area and then down into the calf muscle. Compressions are always performed in a transverse view. This is so you can see the whole circumference, cross-section of the vein clearly and watch it compress. This is one way to record compressions with a split screen with a non-compressed and a compressed view. And you can see that here's the vein here, the artery lateral to it. And then with compression, the vein compresses and the walls coapt, but the artery doesn't compress because, of course, the pressure in the vein is much lower and it compresses with less pressure. And as I said, generally compress at about probe width intervals or a centimeter or so one can examine the entire length of the common femoral vein zone or segment and the popliteal vein segment as well. As far as interpreting the images, they're really just two, as I said, it's all B-mode imaging, and they're basically just two things to look for. One is to visualize the thrombus, and with the better imaging systems that we have now, quite often that's possible. If thrombus is invisible and the lumen is hypoechoic, then compressions are performed, and if the vessel walls don't compress with direct probe pressure, then that's a sign that there is hypoechoic thrombus there. And the compression maneuver originated in the early days of venous duplex scanning when the B-mode images were not that good, and we couldn't really differentiate very well between hypoechoic acute thrombus and flowing blood. The Doppler, as I said, is not required for this exam, but if you know how to use the Doppler and it's available, then that can be used as an adjunct. And so just some images. This is a transverse image of the right common femoral vein. Here's the artery over on the lateral side. And of course, in this image, there's some hypoechoic material in the vessel lumen, and it's easy to make the diagnosis of a deep vein thrombosis. This actually is a popliteal vein thrombus, but it's a longitudinal image, and this can be used to look at the extent of thrombus as well, but not, as I said, for the compression maneuvers. If the vein is fully compressible, that's normal. If it's non-compressible, that's abnormal, and occasionally it's hard to tell, although non-diagnostic exams are not that common once, if an examiner is skilled in the technique. And this just shows the diagrams of compression and non-compressibility. And the video clips here over on this side, here's the common femoral vein. You can see the artery actually is already divided into superficial and deep femoral arteries, but the vein is compressing completely. Here's the popliteal vein coming in from behind. So the popliteal vein is superficial or closer to the skin line, and you can see right there, the vein compressing nicely. And some abnormal examples. Here's a common femoral vein. You can see the artery on top, but the vein compresses about halfway, and when it's compressed, you can see hyperechoic material in the lumen. Not as easy to see when it's non-compressed. In this example of the popliteal vein, there's obviously echogenic material in the popliteal vein. It's not really compressing at all. The tissues are moving, but the vein is not compressing, and so these would be examples of positive studies or abnormal compressions. And here's just one of those systematic review meta-analysis papers that looked at 16 studies using two-zone compression. This is from the emergency medicine literature, because that's a setting in which it's been most widely used and studied. Over 2,000 patients, the overall prevalence of deep vein thrombosis was 23%. Which is fairly typical of these sorts of studies. But the mean sensitivities and specificities for the two-zone compression were in around 96, 97%. So this screening test works very, very well. Again, in the outpatient ambulatory care type setting, it's not as recommended for inpatient or hospitalized patients, since there's a much higher prevalence of isolated calf DVT in that setting. So the two-zone screening test for proximal lower DVT is sensitive and specific. The best results are obtained in symptomatic outpatients. It can be used for the initial treat or don't treat decisions, certainly. It does have limitations. It obviously does not detect calf or below-knee DVT, and it don't detect abnormalities in the IVC and iliac veins. The abnormal or non-diagnostic exam can be followed up with a complete diagnostic venous duplex if that's available. And of course, a normal exam can be repeated if the clinical suspicion remains and there's no other explanation for the patient's symptoms. So the next topic is screening for abdominal aortic aneurysms. This is another thing that could be done in the point of care setting. And screening for abdominal aortic aneurysms has been well studied. There are a number of clinical trials of screening that have shown benefits, both in terms of lowering the incidence of rupture and decreasing aneurysm-related deaths. So this is well studied. Technical guidelines have been published by a number of organizations. In the United States, there's insurance coverage for this sort of examination. And it's recommended by a number of vascular and ultrasound societies and guideline organizations like the U.S. Preventive Services Task Force. And the U.S. Preventive Services Task Force is one of those organizations that looks at evidence and publishes evidence-based guidelines. And this group recommended a one-time screening for AAA in men who are 65 to 75 years of age who have ever smoked, and selective screening in men in that age group who have never smoked. But at the time of this review, this group thought that there was insufficient evidence to assess the benefits in women who have smoked or have never smoked. So they didn't provide any specific recommendations for those groups, but certainly for the men who smoked, that was the highest risk group. And then the Society for Vascular Surgery practice guidelines are similar recommendations, although they go a little bit further in terms of suggesting AAA screening for relatives of patients who are diagnosed with a AAA, and suggested one-time ultrasound screening for men and women older than 75 who would otherwise but be good potential candidates for intervention if an aneurysm was found. But some of these recommendations are weak and based on low quality evidence. So when we think about screening for abdominal aortic aneurysms, really the primary consideration is the risk of rupture, which is related to the diameter of the abdominal aorta, and the risk of rupture appears to start to go up around 5 to 5.5 centimeters in diameter, which is the threshold for an elective repair. And so basically, we're interested in imaging the abdominal aorta and measuring the diameter. Abdominal aortic aneurysms can be palpable on physical exam if they're large and the patient is thin, but the physical exam is not very sensitive and is often limited by a patient's body habitus. The abdominal aorta can be easily imaged with ultrasound, so this is a really good, cost-effective screening test. And it can be used for screening, obviously. It can be used for confirming a physical exam finding if that's the situation. Once an aneurysm is diagnosed, if it's below the threshold size for elective repair, it can be followed or surveyed for enlargement. And of course, we can also use ultrasound to follow up after aneurysm repair, but that is not so much a point of care application. So the diameter is really the key parameter here. The normal infrarenal aorta is usually around 2 centimeters in diameter or less. If it is 3 centimeters or larger, that's considered an aneurysm. If it's just between 3 or 4 centimeters, that's a small aneurysm, but it's an aneurysm by definition. And sometimes we use the term ectatic or dilated if it's just 2 to 3 centimeters, which is kind of borderline. There is some variation in the measurements or variability in the measurements, which is around, by ultrasound, which is around 5 millimeters. So if I look at 2 diameter measurements and they're within 5 millimeters of each other, they may not be clinically different or significantly different. So when we measure the diameter of the abdominal aorta, the convention is to measure outer wall to outer wall. So if you just look at this larger or zoomed in picture on the right-hand side of the slide, you can see the cursor set at the outer wall. And that's the AP measurement as shown there with the proper caliper placement. Here on the left side of the slide is a relatively large abdominal aortic aneurysm. And the AP measurement, as you can see, is a little clearer because the anterior and posterior walls are relatively easy to delineate. This is the transverse view. This is a longitudinal view. And that's so the AP view is usually what we measure and rely on. The transverse view shown here in yellow is not quite as clear because we don't see the lateral and medial walls as well, just because of the way the ultrasound beams intersect the aortic wall. So we tend to rely more on the AP measurement than the transverse measurement, although both are often recorded. So here's a study that looked at the use of point-of-care ultrasound for abdominal aortic aneurysm screening in a VA hospital in the United States. And this was done by the vascular surgery staff and the residents after a period of training, which was relatively brief. They did a little over 100 exams, and of course they were compared to a conventional ultrasound done by trained sonographers. Interestingly, the average time for the exam for the point of care part was 5.3 minutes, not very long. The trained sonographers could do it much quicker at about 3 minutes. But the sensitivity and specificity of the point of care exam was, they were 93%, 97% for detecting an aneurysm. So obviously that's very good. So this is a good test, and it's relatively easy to train people to do in the point of care setting. Moving on to our third topic, just the evaluation of the arterial circulation in the lower extremity for severe ischemia. Um, and physical exam with pulse palpation has not been a reliable method for identifying patients with severe or critical limb ischemia. The evaluation of the pedal pulses with Doppler for this point of care application is just based on audible flow signals. That is what you can hear with your ears, coming out of the Doppler machine. You don't need spectral waveform analysis or anything for this, although if you have waveforms, again, they can be used. But remember that when you're listening to the Doppler signal, you're listening to the Doppler frequency shift, so the higher the pitch, the faster the flow. So for this exam, just need some sort of simple continuous wave Doppler. This is one popular model in many hospitals and clinics in the United States. And when you listen to the Doppler signal down at the level of the foot, either as shown here, the dorsalis pedis or artery, or the posterior tibial artery, which would be over here. First of all, it's just simply, is there a Doppler arterial signal or not? Is it present or is it absent? And if it's absent, obviously that's abnormal. But if it's present, is it normal or is it abnormal sounding? And if it has multiple phases, that's likely to be normal. If it's monophasic, that's abnormal. And if you're scanning over an arterial segment and there's a focal velocity increase, that is a sign that there's a stenosis in that segment. So this is just a qualitative interpretation criteria that can be used at the point of care to get some additional information. And this helps to guide not only initial treatment, but the selection of more detailed tests. And as you do this, remember that if you put the Doppler probe on the artery at a right angle or a vertical like this, that gives you the weakest Doppler signal because of the Doppler equation and the way it works. It's much better if you can apply a 30 or 45 degree angle or some smaller angle down here as shown in this example. So here's the bad angle, which is more like 90 degrees. Here's the better or good angle, which is more like 30, 45 degrees or so. So although I said you don't need waveforms, we use waveforms to describe what we're hearing. And what we want to hear in a normal artery is a multiphasic waveform that has a number of components during each cardiac cycle. And it's represented like this in the waveform, or like this in a spectral waveform. And I can play this for you. This is a multiphasic. So you can hear about 3 or 4 components to each cardiac cycle, and that's a normal peripheral artery. If it's monophasic, if there's just one component for each cardiac cycle, that's abnormal in the peripheral arteries, and it would sound like this. So a normal is multiphasic, but what happens with a stenosis, the stenosis acts like a filter, and it filters out these sort of smaller, rapidly changing components of the signal, and it also dampens it down. And so we get out this, at the other end of the stenosis, we get this monophasic, dampened, sometimes called a tardus parvus waveform. And that is sort of the visual equivalent of what we just heard in those signals. So just some examples. Here's a Doppler signal. And that clearly has 3 phases to each cardiac cycle. So looking at that, if this is a posterior tibial artery signal, this would be a normal posterior tibial artery. Here's a signal from a popliteal artery, as shown there. And so that's monophasic. It just has one component for each cardiac cycle, and it also sounds a little high pitched, and there's not much diastolic flow. I would consider this as a popliteal artery stenosis if it's a focal thing. It also could represent a more distal an artery with a more distal occlusion, but of course that's something that could be sorted out. And here's one last example. This is a mid-thigh Doppler signal. So this is a monophasic signal with a lot of diastolic flow. There's some pulsatility to it. Um, uh, I suppose it could be a stenosis. It's not certainly not an occlusion, but in this case, it actually was an arteriovenous fistula from a gunshot wound. This is actually the. I'll play it one more time for you. And this shows the CT study in the patient where that came from with early filling of the femoral vein in the left thigh there through an arteriovenous fistula. And I should mention before we move on to the next topic, the ankle brachial index, which is easy to do at the point of care, and we do it in the vascular lab routinely as well. This is just obtaining the ankle Doppler signals, the dorsalis pedis or posterior tibial, using a blood pressure cuff at the ankle and measuring the systolic pressure in each of these vessels, and that becomes the ankle systolic pressure, and dividing it by the brachial systolic pressure to kind of normalize it for different ranges of systemic pressures. And the ankle brachial index is a good way just to screen for lower extremity arterial occlusive disease. It doesn't tell you where the occlusions are or what's causing them, but it just tells you that they're there. And one can order more detailed tests if that's indicated. But the sensitivities and specificities are very high. And this is just a table that shows the interpretation of the ankle brachial index. The normal range is 1 to 1.4. If it's less than 0.9, that's clearly abnormal. There's this borderline range just between 0.91 and 0.99. And of course, if the vessels are non-compressible or calcified, that gives you an abnormally high ABI, and that's useful clinical information as well. If there's severe PAD or severe arterial occlusion, the ABI is typically less than about 0.4. And then moving on to one of our other topics, ultrasound-guided vascular access. This is something that applies to almost any patient care setting where one is trying to put in a central line or an IV or to access arteries and veins for interventional procedures. But one of the most prevalent or common applications for this is in central venous access. The use of ultrasound-guided central venous access is supported by a number of organizations based on strong clinical evidence. The use of ultrasound guidance results in lower failure rates, lower complication rates, and fewer attempts before a line is successfully inserted. The greatest benefit has been seen in the internal jugular vein site, although we certainly use it for the subclavian vein and for femoral artery and veins. So there are basically two types of ultrasound-guided guidance or ultrasound-guided, the use of ultrasound guidance. One is static, and the other is described as dynamic. Static means that you locate the target vessel with the ultrasound and mark it on the skin, and then put the ultrasound transducer down and just rely on the mark to access that particular vessel. And this is generally easier for the less experienced users. But it's different than dynamic guidance, in which the ultrasound is used in real time as the vessel or target is accessed. And it tends to be more accurate, but is also technically more difficult. It requires a little more skill and experience. And there are basically two views that we can use for ultrasound guidance: the long axis or in plane view, which is shown in the bottom diagram, which means that the plane of the ultrasound image is in the longitudinal, shows the vessel or the target in a longitudinal view, and the needle has to be in the plane of the image. So that's a little more, requires a little more skill to coordinate the scanning and the access. The other view is the transverse or out of plane view, which is shown schematically in this diagram. And this shows you the target better, and it shows you the location of the needle, but it doesn't show you where the needle tip is, and that's the limitation. And of course, these two approaches are not mutually exclusive, and I would actually recommend using them both at different points in the access or for different types of access. One way of learning this, in a less stressful setting than a patient, is to, if you have access to some sort of simulator training or simulation center, and this is one of those scannable, pokeable simulators. In this case, the Simulad Central Line Man, and this shows a person or technician in the simulation lab using this, looking at the ultrasound image, and in this case, you can see that he's got this in a transverse view as he's trying to access the vessel in the neck there. And so, in these simulators, the transverse view will show you the targets nicely, as shown there. And it'll show you where the needle is. In this case, the needle is there and there, but it doesn't show you the needle tip. In the longitudinal view, as I said, that's a little technically more difficult because you have to coordinate the adjust and manipulate the transducer until you can see the needle in the same plane, and that takes some practice. But then you can see the needle tip as shown there and shown there. And so one way to use both of these approaches is to start with the transverse view, which shows you the target, and that as the needle approaches the target, rotate the scan head to a more longitudinal view and visualize the needle tip in relation to the target, and then access the vessel under direct vision in a longitudinal view. And here's a study that compared the use of dynamic and static and surface landmark guidance for patients undergoing internal jugular vein cannulation. It was a randomized study that looked at cannulation success and first attempt success. And both the dynamic and static ultrasound guidance were significantly superior to simple landmark guidance for this. And dynamic guidance, as you can see, is a little bit better than static guidance, although both were certainly a lot better than landmark guidance. And this is studies like this have led to the recommendation that central venous access should be conducted with ultrasound guidance. And then this doesn't apply to some settings, but if you're involved with femoral artery access or even femoral vein access for interventional procedures, this is a study that was done looking at patients who were undergoing percutaneous endovascular aortic aneurysm repair. And it looked at a series of patients. It was not a randomized study, but some of these patients had just landmark guided access, that is no ultrasound, and some had ultrasound guided access for the arterial access for EVAR. And the access related complications were significantly reduced in the age group, or in the group rather, undergoing ultrasound guided access. There were no complications in that group, but 7% incidence of complications in the landmark access group. Another interesting observation in this study is that the use of ultrasound guidance decreased the overall operative time significantly compared to when ultrasound guidance was not used. And the benefit appeared to be the largest on patients who required large sheath sizes, which is important because the larger sheath sizes are more problematic in terms of access and complication rates. And then finally, just to kind of finish up with the last application that I was going to mention was screening for complications after femoral access, because we do a lot of femoral access for interventions, and sometimes these can cause problems. And the scanning for femoral access complications requires the same basic scanning skills needed for scanning the vessels in the groin, such as we talked about for the two-zone compression test for venous thrombosis. Although we don't just use B mode as we use for that, but we also use Doppler waveforms and color Doppler. And the main complications we're looking for are pseudoaneurysms, venous thrombosis, arteriovenous fistulas, hematomas, arterial stenosis occlusion, and any other vascular injury that can occur as the artery and veins in the groin are accessed. And so here's an example of a waveform in a common femoral artery, which has a lot of diastolic flow, which is not normally present in that vessel. So this would be a hint that is something abnormal going on. The common femoral vein has a high velocity pulsatile flow pattern, and so this would suggest the presence of an arteriovenous fistula. And if one can find the fistula site with the Doppler, it looks like this: high velocity, high diastolic flow, and relatively low pulsatility because of the high diastolic flow, as you can see there. Patients undergoing venous ablation of the great saphenous vein can also develop complications in the groin, and sometimes it's necessary to monitor those patients for venous thrombosis or heat-induced thrombosis. Here are some images that show thrombus going right up in the great saphenous vein, going right up to the common femoral vein. Here's an example of a thrombus that's actually protruding from the saphenous vein into the common femoral vein, both a longitudinal view and a transverse view there. So that may require some additional monitoring or treatment as well. And finally, we do see arterial pseudoaneurysms when the puncture site doesn't seal properly, shown in this color flow image. Here's the common femoral artery. Here's the pseudoaneurysm neck and the pseudoaneurysm flow cavity shown here. The pulse Doppler will show a to and fro or bidirectional flow pattern, which is typical of a pseudoaneurysm neck. And the ultrasound can also be used for ultrasound-guided thrombin injection for treating these lesions. Here's an image showing the needle being placed in the pseudoaneurysm cavity, and the pseudoaneurysm cavity with fresh thrombus in it, no color flow immediately after the pseudoaneurysm injection. So we've been going down for almost 40 minutes, so I'm pretty much on time. These are the vascular applications of point-of-care ultrasound that we've talked about. We talked about compression ultrasound for lower extremity DVT as a screening test. We talked about screening for abdominal aortic aneurysms. We discussed suspected lower extremity ischemia and how to assess the arterial pulses with Doppler and the ankle brachial index. We discussed ultrasound-guided vascular access for the central upper extremity veins, and why this was recommended. And then finally, we just discussed briefly the screening for complications after femoral artery and vein access. So I will stop sharing my screen there, and I think Daria has some questions to follow up.
Yes, definitely. Thank you so much, Dr. Zieler. We do have a quick quiz for our audience. So I'm going to launch the quiz right now so you can test your knowledge and see if you were able to follow what Dr. Zieler covered today. So now you should see 3 questions on your screen, and feel free to respond to those, and we'll discuss the answers shortly, and then we'll go into the Q&A session. So we have a couple of people who submitted questions. Okay. See everyone. I see about 25 people responded to the quiz out of 105 who are watching us live. So take your time. We'll give you a couple of minutes. All right. I'll give you another 30 seconds and we'll show the results. If you do not see the quiz, um, make sure it should be like a pop-up window on your screen. If you're using a mobile phone, it should be showing you in your menu that there is a quiz available, so you should be able to see that. This is not a mandatory quiz. This is just to keep you engaged. So I'm gonna end the poll and share the results. So, Dr. Zieler, do you want to comment on the responses we see for question number one? When performing a two-zone compression ultrasound for DVT, which view should be used for documenting compressibility? Majority answered correctly, which is transverse. We have some people who thought that it may be longitudinal. So if you want to comment on that.
Um, yeah, I didn't see it. Did you show the results on the screen? I didn't see them, but I heard you describe them, so that's fine. Um, no, yeah, the correct answer is transverse, short axis or cross section, and that's so you can see the entire circumference of the vessel compress. If you try to compress the vessel in a longitudinal view, it's easy just to slide off the vessel a little bit and it'll disappear and looks like it might be compressing, but it's not. Transverse view for that particular part of the exam is what is recommended.
Okay, number two, when screened for an abdominal aortic aneurysm, the diameter threshold for the aneurysm is, and the majority of people answered 3 centimeters. We had about 28% who answered 5 centimeters, and a couple of people for 2 and 4 centimeters.
Right. Well, yeah, the correct answer for that particular question is 3 centimeters because that's the threshold for considering an abdominal aorta to be aneurysmal. Those that picked 5 were probably thinking about the threshold for intervention, which is 5 or 5.5, depending on the guidelines that you use. Between 3 and 5 would be an aneurysm, but it would be below the typical threshold for recommending intervention. Although it would be appropriate to recommend some interval surveillance for those patients with smaller aneurysms.
Great, thank you. And the third question, we had a picture, and the question was, what does this Doppler waveform from a posterior tibial artery indicate? And the correct answer was proximal obstruction, and we had 38% answered that, and then 36 chose normal flow, and then 26% chose distal obstruction.
Yeah, so the correct answer was proximal obstruction. Although this was a more difficult one than I think the two because it required a little more interpretation. It's certainly not normal flow in a posterior tibial artery. First of all, it's monophasic. the velocity is very low. I know it might be hard to read the velocity there, but it's about 21 centimeters per second. Um, and the systolic upstroke is slightly delayed, which would indicate more proximal obstruction. There's no diastolic flow, so that could go along with distal obstruction, but the delay would point more to something proximally. So I think the best answer is proximal obstruction, although I can see why someone might put distal obstruction, although it's certainly not normal flow.
Thank you so much for sharing your knowledge with us, and thank you everyone for testing your knowledge. So now we'll go into the Q&A session. We have a couple of questions coming in from the audience. So the first question is, how do you distinguish a chronic from acute DVT? I often see ED patients on I'm sorry, I cannot pronounce this word.
Anticoagulants, yes.
There you go. Presenting with leg swelling.
Yeah. Yeah. Well, that's actually a good question. Uh, but it doesn't have an easy answer. There are some features. First of all, it's difficult to distinguish acute from chronic DVT on ultrasound alone, although there are some features which are definitely point us more toward the acute versus a chronic. But there's no way to actually tell how old or how long a thrombus has been there in terms of days or weeks or months. But the features that would point to a more acute process are a very hypoechoic or dark material in the vein. If it's partially compressible or spongy, if it has a partially attached or mobile component, those are all features which would point to a more acute thrombus. The features that would point to a more chronic process would be a smaller contracted vein, a brighter echogenic material in the lumen, and perhaps reflux yeah, or valvular incompetence as well. So when we do an exam in the vascular lab, we do try to make some comment on whether we think it's acute or chronic, based on those features. And if it is difficult to tell or it has features of both, then the term we use is age indeterminate, which just means it's hard to tell.
Thank you. And is it sufficient to examine abdominal aorta in transverse view, or do I need to study in longitudinal too?
Well, a good question. So, as far as the view used for a AAA screening, the exam that we discussed, or the application that we discussed, a transverse view is all you really need. If a examiner is comfortable doing a longitudinal view just to see what the aorta looks like in that in that view, that's fine. But as far as the actual measurements and documenting the exam, the transverse view is recommended.
Thank you. We have a question from Lloyd. What makes the abdominal aorta at a greater risk for aneurysm compared to other arteries?
Well, that's it's a good question. It's a complicated question. Certainly, the abdominal aorta is the commonest site for aneurysms. I think in general, certainly in the aorta, but I think in the body in general. And I guess one short answer is we don't know for sure why that particular segment is susceptible. There's some sort of theoretical ideas about it. One is that the aneurysm is relatively fixed posteriorly to the anterior longitudinal ligament of the spine, and it may be subject to more stress because of that, and also because the infrarenal aorta is close to the aortic bifurcation. A lot of the energy that is used to move the blood along reflects from the iliac bifurcation back up into the abdominal aorta. So that segment of the aorta has a number of factors that make it more susceptible to stress, so that the wall may be more susceptible to weakening there. But I think the bottom line is that nobody really knows exactly why that segment is so susceptible.
Thank you. Another question from Jonathan. There are methods for measuring true volume flow. These methods can be used in POCUS ultrasound machines. They're also angle independent for measurements. It seems that it would be very useful in areas like flow determination and ischemic disease.
Yeah, volume. So volume flow can be measured with ultrasound, as it's pointed out there. There are a number of assumptions that go into it, like circular cross-sectional area and a uniform flow pattern and so on. Um, uh, and so one can measure volume flow in a popliteal artery or a superficial femoral artery, and get a number. The problem is that in critical limb ischemia, the numbers are going to be very low, and we really don't have any specific thresholds for knowing what those numbers mean. Just like it's difficult to know exactly what the peak systolic velocities mean. But there hasn't been a lot of work done with volume flow in critical limb ischemia, so that's an area that you know somebody could investigate further. But typically we don't look at volume flow in the peripheral arteries um, for diagnostic purposes very much. It's a good question though.
Thank you. Question from Matt. I have noticed with the higher frequency probes that go up to 21 or 22 megahertz, you can see venous flow, but as long as you see compressions, this would not be concerning, just a result of the higher megahertz.
Um, so so the higher frequency transducers, um, they certainly they would show you a vein flow in an artery or a vein. Um, I'm not sure if he means a B mode transducer or a Doppler transducer, but certainly with B mode, the depth penetration for a very high frequency transducer wouldn't be very great. So any vein you would examine with a 20 megahertz transducer would be relatively superficial, um, but you'd certainly get a good quality image, a better quality image. I mean, we use high frequency transducers for things like screening for giant cell arteritis, which are small vessels which are superficially located. But uh, no reason why you couldn't use that for a venous exam as long as the veins are very superficial.
Thank you. Question, how to tell difference between veins post-sclerotherapy and thrombosis?
Ooh. Well, after sclerotherapy, the veins are usually contracted and scarred and occluded, of course. Um, but it's hard to see. You may not see much of a lumen. If a vein is just thrombosed, the lumen is usually still quite visible with echogenic material in it. Although I acknowledge that it might be difficult in some cases to differentiate between uh, a thrombosed superficial vein and a sclerosed vein, but typically the sclerosed vein would be um, more of a scar and have less of a lumen.
Thank you. Next question. I'm not sure if it's the question. How about apply in plain view for vascular access?
Oh, in plain view. Well, that was an oblique in plain view. Well, I mean, I think,
Mhm.
I mean, any view where you can see the vessel well and the needle, if that's what you're using, is helpful. Um, but the longitudinal and transverse views are basically the two ways to describe views. I mean, if you come in at a oblique angle and you're in plane, that's basically another. I think that's just another way of describing a longitudinal view, I think.
And at what level should we scan for AAA?
At what level? Well, I think the guidelines say that you should try to get multiple measurements along the infrarenal aorta from as high up as you can scan, which could be as high up as the xiphoid process in the upper abdomen, down to the bifurcation into the iliac arteries, which would be about at about the level of the umbilicus. So basically, from the umbilicus to the xiphoid process, try to visualize the abdominal aorta and get 2 or 3 diameter measurements.
Thank you. Do you have an ultrasound screening protocol for the diagnosis of lymphedema in the US?
Um, that's an interesting question. The answer is no. We don't have a diagnostic protocol for screening for lymphedema. I mean, it's not a condition that we, you know, diagnose with ultrasound. It's more of a clinical diagnosis. Although I think the main role of ultrasound in that setting is to rule out other causes like chronic venous insufficiency and um, things like that. So ultrasound can play a role in the workup of patients with lymphedema, but not specifically for diagnosing lymphedema itself.
You. And Matt has another question. After you have a negative leg DVT study, what do you tell the patient? Is the scan good for any time period, 1 week, or until more symptoms develop? May not have proximal DVT today, but could develop in 1 week because did not scan lower cuff.
Well, yeah, that's a good question because that speaks to how we use the screening exam and how it integrates with other tests and clinical management. If a patient has a negative um, two-zone compression for DVT, that's a very good indicator that they don't have a proximal DVT at that particular point. So the options are well, first of all, you have to see if there are any other causes for the patient's symptoms. If it's musculoskeletal pain or something like that, if they have a sprained ankle or something. So there may be tests that you can do for that. If no other cause is found and there's still a high suspicion for deep vein thrombosis, the option, if you can get a whole leg ultrasound in a vascular lab or radiology department, looking for an isolated calf DVT or something like that, then that's one option. The other option, another thing to do if that's not available, is to repeat the test in a few days to see if the patient may have had an isolated calf DVT and it propagates up and becomes a more proximal DVT, or if their symptoms progress, repeat the exam. So those are some of the options. Another option, again, if it's available, is to get a D dimer on the patient, which is a blood test. If the D dimer is negative and the two-zone compression test is negative, that's very good evidence that the patient does not have a DVT anywhere. On the other hand, if the D dimer is positive, that's less helpful because the patient still may or may not have a DVT with a negative two-zone. So those are some options. It's a complicated question because they can be complicated patients, but nevertheless, the two-zone compression test is a good place to start.
Thank you. We have 2 minutes left, so I'll try my best to go through all of the questions. And if we don't answer your questions, we may follow up with the email. The next question is, how can I identify a sacral aneurysm when it is at the lateral of the abdominal aorta if I'm measuring a P diameter of the wall?
Right. Well, yeah, saccular aneurysms can be very focal. So again, unless you image at frequent intervals, one can miss them. I mean, I guess that is a reason to do longitudinal views because it's easier to see a saccular aneurysm in a longitudinal view, probably, of the abdominal aorta, or to take multiple measurements. But yeah, a careful exam in multiple views would be the best way to find those, a saccular aneurysm.
Thank you. People are asking if you would be willing to present on upper extremity DVT in the future. So we can definitely follow up with Dr. Zieler if he's interested and has time. But thank you for sending that suggestion.
Yeah.
And the other question is, how do we interrogate endoleaks in the post-EVAR patients?
Yeah, and well, looking for endoleaks in after endovascular aortic aneurysm repair, that's a whole nother topic. In fact, I could give a whole talk on just on that topic, and I could certainly do that. It's an interesting question. That's certainly that I wouldn't say that's a point of care application. So it's certainly an application for ultrasound, and it's done frequently in our vascular lab. And in fact, we even have a program we started within the past couple of years to use ultrasound contrast for that. So again, and that's another topic, a topic for another time. But that's certainly something that we can do, and I'd be happy to talk about that if enough people are interested. But I say it's not really a point of care application.
Thank you. And the last question, can you send any or share any suggestions of books for people or resources that are available to read or watch?
Wow. I'm not aware of a lot of good resources for vascular point of care. I mean, there are lots of resources for point of care, um, including those that are, offered by the point of care academy, but certification academy. But as far as resources for point of care vascular, um, well, if you're interested in standards and guidelines for some of these exams, like DVT and aortic aneurysm screening, the Intersocietal Accreditation Commission standards are available online. They don't cost anything. You can read them. And they have some guidelines for for some of the vascular applications. Some of the vascular societies, like the Society for Vascular Ultrasound, I think the and some of the other ultrasound societies on their websites have guidelines and protocols for screening. So uh, uh, we can certainly I could put a few things together and we can send it out in a follow-up email. But that's a good question. But there are resources available that are at no cost that people can use.
Thank you. And we definitely have a couple of resources available on our website that you can access, some infographics and podcasts and webinars. So feel free to go to POCUS.org and go under the educational tab where you can find some of the additional resources. But I don't have any more questions that have been submitted. So thank you, everyone, for your participation. This was recorded, and you will be able to access the recording within the next week. We'll send you an email. And we also wanted you to submit your feedback. Right now, you should see on the screen another poll that you can tell us your feedback about this webinar and make any suggestions. So this helps us plan for the future. And I want to personally thank Dr. Zieler for taking his time to present with us today, and certainly we'll be back with more information about his future presentation. He would like to join us, but thank you so much, Dr. Zieler, and thank you everyone for taking the time to join us today.
Okay. Thank you, everybody.
Thank you.
Mhm.